Today, we are going to learn about identification and initial care of sick neonates, triage assessment, pre-referral or transport stabilization, and care during transport. In this session, we will learn how to recognize life-threatening danger signs in a neonate and triaging, initial treatment and stabilization of a neonate who is critically ill, take a brief neonatal history and maternal history, do neonatal examination for other danger signs that may need further management, and provide care during transport of a sick neonate. Why is rapid assessment required? Neonates with life-threatening conditions need prompt recognition and management as their condition can deteriorate very rapidly. We need to focus on few specific danger signs and minimal supportive investigations to arrive at a diagnosis without wasting precious time. Overview of Sheet A. Sheet A is used to evaluate all neonates for emergency signs on arrival to the hospital and to provide prompt, appropriate management. On the right-hand corner, we have the emergency signs that we need to look for in the neonate. Right in the middle are listed a probable diagnosis, and on the left side, we have the immediate management of emergencies. We will follow ABC sequence, that is, airway, breathing, and circulation, as in resuscitation, while evaluating the neonate for danger signs. Remember that a neonate may present with more than one condition. For example, a neonate with bleeding may also have low body temperature. We need to first manage the ones that will rapidly kill the baby. Ideally, all sick neonates need weight and temperature and blood sugar measurement and saturation reporting by pulse oximeter. Identification and management of apnea or gasping respiration. One of the first signs we need to assess in a neonate is the respiration. Count the respiration for 1 full minute. Look for gasping. Gasping is a periodic shallow breath that is ineffective to maintain oxygenation. If neonate is not breathing at all, even when stimulated, or there is gasping respiration, or respiratory rate is less than 20 per minute, classify the neonate as having apnea or gasping respiration. Immediately start positive pressure ventilation with a self-inflating resuscitation bag at the rate of 40 to 60 breaths per minute. You can follow the sequence of breathe 2-3, breathe 2-3 to maintain the correct rate of breaths. Connect oxygen at 5 to 6 liters per minute if available. Continue giving oxygen after return of spontaneous respiration. Connect pulse oximeter if available and adjust flow meter according to neonate's requirement. Identification and management of shock. The next step is to assess for the pulse or heart rate and capillary refill time. Heart rate is counted for 6 seconds and then multiplied by 10. For example, 12 beats in 6 seconds is 12 into 10, which will give us 120 beats per minute. Capillary refill time is checked by pressing the thumb on the upper portion of the sternum for 5 seconds. Keep timing by counting 1001, 1002 till 1005. Withdraw the thumb and observe the time taken for reperfusion while counting from 1001 to 1003. If the neonate is having weak or fast pulse, that is, heart rate and extremities are cold to touch, and capillary refill time is more than 3 seconds, with or without pallor, and the baby looks lethargic or is unconscious, this baby is most likely to be in shock, and we need to start management for shock. If bleeding is the likely cause of shock, infuse normal saline 10 milliliter per kg body weight over 10 minutes with maximum of 3 boluses over 1 hour. Give blood transfusion. Stop external bleeding. Look for probable sites of bleeding like the umbilicus and genitals in males in case of circumcision. Give vitamin K intravenously. If bleeding is not the likely cause of shock, give 10 milliliter per kg normal saline over 10 minutes with maximum of 3 boluses over 1 hour and reassess the baby. Identification and management of seizures. Look for signs of seizure activity in neonates. This may manifest as ocular, characterized by tonic horizontal deviation of eyes or sustained eye opening with ocular fixation or cyclical fluttering. Oral facial wrinkle movements such as chewing, tongue thrusting, lip smacking, etc. Limb movements such as cycling, paddling, boxing jabs, etc. Autonomic phenomena such as tachycardia or bradycardia or clonic seizures and tonic seizures. Clonic seizures are rhythmic movements of muscle groups. Tonic seizures refers to a sustained flexion or extension of axial or appendicular muscle groups. If the neonate has signs of seizure activity, manage airways, check and manage low blood glucose, check calcium, and give anticonvulsants. Identification and management of low blood glucose and hypothermia. If the blood sugar is less than 45 mg per deciliter, treat the baby for hypoglycemia following standard treatment protocol. If the neonate's axillary temperature is less than 36 degrees Celsius, treat the baby for moderate to severe hypothermia. Keep under rate and warmer if the baby's temperature is less than 32 degrees Celsius. Rapidly rewarm in the manual mode at 100 degree heater output till baby's temperature reaches 34 degrees Celsius, and then gradually rewarm the baby to bring the temperature up to the normal range. Overview of Sheet B. Assessment for specific conditions. After emergency management and stabilization of the neonate, or if emergency signs are absent, we shall move to Sheet B. In Sheet B, we ask the caregiver for a pre-neonatal and maternal history. We look, listen, and feel for signs and symptoms that will help us arrive at a specific diagnosis. Taking neonatal history, we ask for age of the neonate and the birth weight if available. Was the baby born term? If not, then at what gestation? Delayed crying, not breathing at birth, requirement of bag and mask ventilation at birth. Is the baby having any other problem in feeding, choking, or vomiting? When did the problem start? Has the baby worsened? Maternal history. Ask for medical, obstetric, and social history. Pregnancy. Duration, chronic diseases, HIV, any complications, history of maternal fever. Labor. Any complications, duration of rupture of membranes, fetal distress, prolonged labor, cesarean section, color and smell of amniotic fluid, instrumental delivery, vaginal delivery, malposition, malpresentation, administration of antenatal steroids if baby was born before 34 weeks, social history, support system, economic status, personal habits, etc. Neonatal examination. Recheck temperature, heart rate, respiratory rate if taken more than 30 minutes before. Assess for severe chest indrawing, grunting, central sinuses, abdominal distension and or vomiting, seizures, lethargy, jaundice, or any other obvious abnormality. Following neonatal examination, classify the neonate's condition as follows. For newborn with hypothermia, that is, body temperature less than 36.5 degrees Celsius, follow standard treatment protocol for neonatal hypothermia. For newborn with hypoglycemia, follow the respective standard treatment protocol. If baby is preterm, follow standard treatment protocol for feeding low birth weight or sick newborn. Follow respective standard treatment protocol for these newborn conditions: neonate with jaundice, neonate with blood asphyxia requiring bag and mask ventilation or intubation or drugs at birth, neonate with breathing difficulty, neonate with seizure, and neonate with sepsis. One should suspect sepsis if any of the following signs are present: breathing difficulty or abnormal movements, unconscious or lethargic, not feeding or poor feeding, abdominal distension or vomiting, or if maternal risk factors for sepsis are present. It may be very important to understand that baby may have more than one condition to treat, so look for all conditions. Key components of a neonatal transport system. Transportation of the sick or preterm babies to a center with expertise and facilities for the provision of multi-organ intensive care has been shown to improve outcomes. With the initiative of state governments in developing special care newborn units at district hospitals, many of the sick neonates can be provided better newborn care if they are timely transported in a stable condition. The key components of a neonatal transport system are human resource, vehicles and equipments, pre-transport stabilization, communication and documentation, and feedback to referring unit. Human resource. Human resource can be the doctor or nurse in organized neonatal transport service or accompanying person in case of community transport, which could be an ASHA worker, A&M, a paramedic trained or untrained, or a family member who should be trained in essential newborn care during transport, identification of danger signs, and their immediate remedy. Vehicle and equipment. The ambulance used for neonatal transport should, at a minimum, meet the requirements of a basic life support ambulance. Basic equipments for transport include power backup, gases, ventilator, transport incubator, syringe pumps, and monitors. Pre-transport stabilization. Pre-transport stabilization is the most vital step in the whole process of transport. We will discuss more on this a little later. Communication and documentation. Adequate and timely communication with the family, referring hospital, and the support group is essential. Documentation should include patient's demographic details, name, age, sex, gestational age and weight, place and name of referring hospital, reason for transfer, detailed perinatal history, labor and delivery, neonatal resuscitation, current patient status, therapy and laboratory data, potential for deterioration and need for advanced therapy like mechanical ventilation and exchange transfusion or diagnostic evaluation, referral note with provisional diagnosis and treatment given so far, and consent form from parents. Feedback to referring unit. Team at referral center shall call or send a written communication to the members of referring unit regarding the condition of the baby with details of medical illness, likely diagnosis, prognosis, and likely duration of stay. Principles of pre-transport stabilization. Pre-transport stabilization of a sick neonate follows the following principles. Temperature. Correct hypothermia if present before transport. Use methods like kangaroo mother care, provide warm clothing, or keep baby under radiant warmer at stabilization unit or referring center as most transport incubators are not able to actively warm the hypothermic baby. Airway. Assess airway for presence of any secretions. Suction if present, and maintain position of neck. Place a soldier rod if needed. Breathing. Assess for respiratory distress. Assess whether baby requires ventilation. Circulation. Check heart rate, capillary refill time, urine output, blood pressure if feasible. Assess the need for fluid bolus. Check what fluids baby is getting and whether baby is on inotropes. Adjust infusion of inotropes as per need. Blood sugar. Check blood sugar with glucometer. If blood glucose is less than 40 milligrams per deciliter, give 2 milliliters per kg of 10% dextrose through intravenous line. Check dependency of intravenous cannula and start IV fluids. Care during transport. Ensure temperature, airway, breathing and circulation. If possible, let a health care provider accompany the baby. If not possible, explain family the care to be provided during transport. Keep baby's trunk and palms and soles warm to touch. Keep airway open. Physical stimulation if apneic. Provision for feeding if required. It is best not to attempt feeding sick babies with abnormal sensorium or severe respiratory distress before or during transfer. A well baby at risk of hypoglycemia may be fed in addition to IV infusion. If baby can accept, provide breastfeeds. If not, give expressed breast milk with spoon or baladai. Take baby to nearest facility by fastest mode of transport by the shortest route. Communication for neonatal transport. Subsequent to decision for transport, communicate with parents and family about nature and severity of illness and the need for transport. Facilities available at referral hospital, including infrastructure, details of key personnel, give examples of previous successful transfers and outcomes. Type and mode of transport and time needed to reach the referral hospital, names and contact numbers of key personnel at referral hospital, and possible need for emergency procedures during transport. Communication to the referring center. Success of transport process depends on the effective communication between the referral and receiving institute. The availability of bed should be asked before starting transport, and referred hospital should be informed in advance. Communication during transport. Mobile telephones should be made available to contact referring or referral hospital in case of any emergency or breakdown. It also helps to inform approximate time the transport team is likely to reach the referral hospital. This helps especially when the NICU is away from the emergency services where the transport vehicle is likely to reach. To avoid destabilization, the team from the referral center should preferably receive the neonate at the entry to the hospital. Feedback communication with referring center. Team at referral center shall call or send a written communication to the members of referring regarding the condition of the baby with details of medical illness, likely diagnosis, prognosis, and likely duration of stay. Once improved and stable, the infant may be transported back, reverse transport, for ongoing care with written details of treatment details and its duration. Medico-legal issues associated with transport. Most of the medico-legal issues associated with transport are a result of poor communication and provision of inadequate information. The condition of baby, risks involved during transport, and financial implications of transport and treatment at the referral center should be discussed with family and documented in the case report. If baby dies during transport, cardiopulmonary resuscitation should be performed as per Neonatal Resuscitation Program guidelines, he or she should be first taken to the higher health facility. Casualty admission should be done. Parents should be informed and death certificate made by the medical personnel of higher health care facility. It is the responsibility of the transport team to make death certificate of the baby. To summarize, in this session we have learned about identification of danger signs in a neonate and triaging, initial treatment and stabilization of a neonate who is critically ill, neonatal and maternal history, neonatal examination for other danger signs that need further management, key components of neonatal transport system, and care during transport of a sick neonate. Thank you.